Begin with gastrointestinal system first year revision. So first thing we need to know about gastrointestinal is embryology. So here you need to know that gastrointestinal system is of endodermal origin. So all the GI tract starting from the esophagus till the rectum, it is lined by endoderm. That is, it is originating from the endoderm. And not only GI tract, even the liver, pancreas, trachea, all are from endodermal origin. And the mesodermal origin structures are like stroma, peritoneum, muscles and spleen. Remember that spleen is the only organ which is coming from the mesoderm, which is related to this GI system, and also the stroma, whatever the stroma of the cells, and also the peritoneum, muscles. Of course we know mesoderm gives rise to muscles, even the peritoneum is coming from mesoderm, but the major structures like GI tract, liver, pancreas, trachea are coming from endoderm. So let us understand the normal embryology of the GI system. So actually you know that it is divided into foregut, midgut and hindgut. So foregut is starting from the esophagus. If you can take this as an example, it will start from the esophagus and it continues up to the duodenum, especially at which side of duodenum, where the ampulla of Vater opens. You know what is ampulla of Vater? Where the pancreatic duct and the common bile duct insert, right? So the ampulla of Vater, the pancreatic duct and the common bile duct which is coming from the liver, both of them drain here into major duodenal papilla here. So from the esophagus to the first part, you can say like about first part of duodenum is the foregut. Next comes the midgut, which is from the lower duodenum, this lower duodenum, to proximal two-third, this yellow color you can see, this proximal two-third of transverse colon is whole supplied by midgut. That is from the lower part of duodenum to this transverse two-third. Next coming to hindgut, this orange part is supplied by hindgut, that is distal one-third of transverse colon to the anal canal above the pectinate line. Actually somewhere here lies the pectinate line, so it's still till above pectinate line it is whole hindgut. So very important thing about midgut is, you can see this yellow color, this midgut actually in the 6th week what happens is there is herniation of the midgut through umbilical ring. Here you can see this yellow herniation, and this herniation again normally it is a physiological process, so later again it comes back into the position by 10th week and it rotates around the superior mesenteric artery. You can see here this is a superior mesenteric artery, so it comes inside and it rotates around the superior mesenteric artery, that is about 270 degrees counterclockwise, and it is a normal physiological herniation. But there are some conditions like in which this herniation is there even after the birth, and that is called as omphalocele. I will discuss that. Okay, and one more thing you need to know about the blood supply. The foregut is supplied by the celiac trunk, okay, and the midgut is supplied by superior mesenteric artery, and the hindgut is supplied by inferior mesenteric artery. And one more thing, even the lung bud is developing from the foregut, but it is separated by the tracheoesophageal septum. If you remember, here lies the esophagus, and also trachea is for our it is connected to the lungs, right? So this tracheoesophageal septum is what which separates the lung buds from foregut. Okay, and there's one thing that if the tracheoesophageal septum deviates posteriorly, then it will cause esophageal atresia, because if this septum it's growing and if it is going like this posteriorly, it will close the esophagus and that will lead to esophageal atresia. Next coming to mesentery. Actually mesentery is a double layer of peritoneum. It is divided into dorsal mesentery and ventral mesentery. What is this? Actually mesentery is which covers all this GI organs especially. So dorsal mesentery means backside, ventral means front side. So ventral mesentery actually covers our stomach, liver and also esophagus. And very important thing, liver grows into the ventral mesentery. Okay, stomach and esophagus are covered by ventral mesentery, and this ventral mesentery is mainly derived from septum transversum. Of course you can't see here the mesentery, just imagine that it is covering all of these organs. It is derived from septum transversum. And in adult, this ventral mesentery will form lesser omentum. What is lesser omentum? Lesser omentum is starting from the lesser curvature of the stomach and it is connecting to the livers. That is a lesser omentum, and remember it is arising from the ventral mesentery. And also falciform ligament will arise from the ventral mesentery. Falciform ligament is a ligament which is coming from the liver to the anterior abdominal wall. For example, this is the anterior abdominal wall, and from liver to anterior abdominal wall there is a falciform ligament. And next, greater omentum. It is coming from the greater curvature of the stomach. Okay, from the greater curvature of stomach there will come the greater omentum, which is a mesogastrium. So this lesser omentum is coming from ventral mesentery, whereas this greater omentum is coming from mesogastrium. Okay, and this is what we need to know. And lesser omentum is between the stomach and liver, which is ventral mesentery. Done. Now let us discuss some ventral wall defects. So ventral wall defects, according to some developmental problems in the wall, that defects are according to location. If there are rostral fold problems, then that will lead to sternal defects, that is called ectopia cordis. If there is lateral fold problem, that will lead to omphalocele and gastroschisis. If there is called caudal fold problem, that is called caudal fold is not able to close, that will lead to bladder extrosophy. So first we'll discuss the main two diseases, that is a gastroschisis and omphalospleen. Actually in gastroschisis the problem is paraumbilical. For example, this is umbilicus here you can see, but right to the umbilicus there's an abdominal wall defect, and from that the intestine is coming out, that is called as gastroschisis. And here the problem is in the abdominal wall weakness, but not in the umbilicus. Okay, that is important. So it is associated with poor GI function because all the intestine is coming out, and especially we'll see this in babies. So that will lead to atresia and stenosis of the GI system, and this is not associated with any chromosome abnormalities. It is having good prognosis. Okay, and here let us see omphalocele. Omphalocele is directly, you can see from the umbilicus the abdominal contents are coming. How to remember this? You can see the contents which are coming are forming a O shape. So like that you can remember omphalocele. And very important thing, omphalocele is covered by peritoneum and also it is covered by amnion. But here there is no peritoneum and amnion because it is coming from the side of umbilicus, but it is directly coming from umbilicus. So it is covered by peritoneum and amnion, and it is sealed like a O shape. Okay, and there are many abnormalities associated with it, like trisomy 13, 18, Beckwith-Weidman syndrome, and cardiac, GU, neural tube defects, orofacial clefts, neural tube defects, Down syndrome, all these are affected. Now coming to congenital umbilical hernia. It's a congenital problem that there's a failure of umbilical ring to close. As the umbilical ring is failing to close, the intestinal content is herniating through that, especially from the midgut. It is a physiological herniation. As I said before, in the 6th week the herniation will come, and by 10th week it goes. But if it is remaining in the same way, that is a congenital umbilical hernia, and this will protrude more whenever there is increased abdominal pressure, like coughing or crying in the case of baby. So this is associated with again Down syndrome, congenital hypothyroidism, and small defects that usually close spontaneously. So next, coming to peritoneum cavity. Peritoneum cavity is actually having a greater sac and lesser sac. For example, if you take a cut section of your intestine, this is a lesser sac, this will be the greater sac. Okay, greater sac, lesser sac. Greater sac is where it is starting from the diaphragm to the pelvic floor below, and the lesser sac is actually closed space. It is behind liver. Here will be liver, here will be stomach, here will be lesser omentum between liver and stomach, and back of that space is called lesser omentum. And there is a foramen called epiploic foramen. Epiploic foramen, also called foramen of Wilson. From here the greater and lesser sac can communicate. Now let us discuss tracheoesophageal anomalies. So normally this is the esophagus and this is the trachea. You can see this is a pure esophageal atresia because of constriction of esophagus, and you can see this is a H type, which is where there is a projection from the esophagus which is connecting to the trachea, and you can see here this is where the esophagus has undergone atresia completely, that is it is completely blocked, and from lower part you can see the distal esophagus is in connection with the trachea, and this is called tracheoesophageal fistula. Because of this fistula, what happens is the child is unable to swallow anything, and that is leading to polyhydramnios in the newborn child. And because of this fistula, there is a air which is passing from the trachea to the esophagus, and now this esophagus connects to stomach, so that will lead to prominent gastric bubble in the stomach. Even in this case, pure tracheoesophageal fistula, you can see this is a H type. Here also you can see there is a gas bubble in the stomach because of this connection. But whereas if there is no fistula, I can see there is no gas bubble. Among all these types, this is most common, that is with atresia, esophageal atresia and tracheoesophageal fistula. This is the most common type, that is 85%, it is most common. So how to clinically test this? If we try to pass a nasogastric tube, it fails to go because of this atresia, it coils up here, and like that you can find out. In H type, especially the fistula resembles a letter H. In pure EA, you can see the chest X-ray shows gasless abdomen. That is a characteristic feature. Now coming to intestinal atresia. Actually, first atresia is duodenal atresia. That is you can see double bubble sign on X-ray, because the stomach will get blown up and the duodenal will get distal part of duodenal will get blown up, because there's a constriction here in the duodenum. That's why duodenal atresia, right? So as there is atresia of duodenum, you can see how they are bulging up, and this is seen just after 2 days of a life. In the case of baby, the baby presents with bilious bilious vomiting, because it has entered duodenum, right? In the duodenum there will be common bile duct and pancreatic duct entering, so there will be bilious vomiting in the baby, and this is what you see in X-ray, that is a double bubble sign, and this is also associated with Down syndrome. Next, another atresia is jejunal and ileal atresia. Of course, the diagram is not here, you can understand. Here all the three structures are swollen, that is the stomach is swollen, the duodenum will be swollen, and also the jejunum will be swollen because of this atresia. And typically, there is why this problem is because of superior mesenteric artery. Superior mesenteric artery supply the midgut structure, so when it get infarcted, even that structures which is supplying blood to them, they'll get ischemic, and because of that there is a triple bubble sign and gasless colon. This is also associated with cystic fibrosis, and this is caused mainly because some maternal age where the parent is having cigarette smoking, all those habits, and also because of this it is linked to vasoconstrictive drugs, and because of using vasoconstrictive drugs like cocaine during pregnancy, and also bowel will be distal to blind end. So whatever the bowel which is distal to the blind end will undergo apple peel atresia. Next, hypertrophic pyloric stenosis. You can see the narrowing of the pylorus, so because of that the food is not able to pass, and that will lead to again vomiting. But here this is non-bilious vomiting, because it is still not reaching the duodenum. You can see the thickened and lengthened pylorus. So in the baby, in the epigastrium, you can feel some olive shape like structure because of this mass. It is seen in 2 to 6 weeks year old, and also can feel that in the visible peristaltic waves you can feel on the epigastric region. This is most common in a male child, first born male, you can see here clearly, and this is also associated with exposure to macrolides drugs. This will result in hypokalemic, hypochloremic metabolic acidosis, especially after vomiting, because you lose all the nutrients like potassium, chlorine, and that is also linked to metabolic alkalosis. Next, ultrasound shows thickened and lengthened pylorus. Treatment is surgical incision of pyloric muscle, that is we need to remove this pyloromyotomy. Next, coming to pancreas and spleen. So pancreas, actually it is present as ventral bud and dorsal bud. Actually this ventral bud also comes here and joined with the dorsal bud and form a complete pancreas. Ventral bud actually forms the uncinate process and also the main pancreatic duct, and the dorsal pancreatic duct in this accessory duct, you can say accessory duct, and also the main pancreatic duct, all this fuse together and they open into the major duodenal papilla here into the duodenum. So actually there is a condition like annular pancreas. In this diagram you can see the pancreas, actually they are having an abnormal rotation of the ventral and dorsal bud, so that is leading a ring formation, and this ring is trying to block the second part of duodenum. So this is causing duodenal narrowing and also associated with Down syndrome, and also this causes the vomiting because the duodenum is obstructed. And next, coming to pancreatic division, like this only the pancreas remain, that is the ventral will be on this side and dorsal will be on this side. Actually this doesn't cause that much problem, it is asymptomatic, but sometimes it may lead to chronic abdominal pain and also pancreatitis. Next, coming to spleen. Spleen usually arises in the mesentery of stomach, especially from mesoderm. As we discussed, all major GI structures are coming from endoderm, but spleen is the one which is coming mainly from the mesoderm. but it has still the foregut supply, that is celiac trunk only supplies the spleen by splenic artery, and this spleen can connect to the stomach by gastrolineal ligament, short gastric artery, and also left gastroepiploic artery. Coming to pancreas. Pancreas are first intraperitoneal, but later they fuse with the posterior wall and become retroperitoneal. Retroperitoneal means they're only lined by one side. They're only covered only one side by peritoneum. Okay, first they're intraperitoneal, that is they're covered two sides, but later they become retroperitoneal. In divisum, accessory dorsal duct drains majority of pancreas. So actually in divisum, here ventral pancreatic duct will be here, dorsal will be here. So mainly the accessory duct will drain most of the pancreatic juices if they are like this, if they are still in a divisum state, and this may also cause pancreatitis. Now let us learn retroperitoneal structures. So actually retroperitoneal structures are which are posterior or outside of peritoneal cavity. So you can see here, this is the peritoneum covering all the organs on the one side like this, and these are the structures which are retroperitoneal. You can see here the inferior vena cava, aorta, kidneys, right? So they are actually covered only on one side. On the back side again there's abdominal wall, posterior abdominal wall. So these structures are called retroperitoneal structures. They can cause blood or gas accumulation in retroperitoneal space whenever they are getting injured, right? If they are injured, they'll cause or blood accumulation or gas accumulation in this space. So how to remember the retroperitoneal structures? You can remember by that mnemonic SAD pucker. SAD pucker. S suprarenal means adrenal glands are retroperitoneal. A aorta and IVC. You can see here aorta and IVC are retroperitoneal, and duodenum second through fourth part. Duodenum second to fourth part are retroperitoneum, and pancreas except tail. Pancreatic head is not, pancreatic tail. Of course it's not shown here. Pancreatic tail is retroperitoneum, and ureter is also retroperitoneal. Colon, descending and ascending colon are you can see ascending colon, descending colon. So this is retroperitoneal. Kidneys are retroperitoneal. Esophagus is retroperitoneal. Okay, next rectum is also retroperitoneal. So remember this SAD pucker. These are all retroperitoneal. Next, coming to intraperitoneal structures, like stomach is intraperitoneal, appendix, liver, spleen. Actually I'm just saying this, if you remember retroperitoneum, that is enough. And first part of duodenum, because whatever are retroperitoneum are not intraperitoneal, right? So jejunum, ileum, transverse and sigmoid colon, rectum, pancreatic tail. Okay, pancreatic head is actually retroperitoneum, pancreatic tail is intraperitoneum. Now let us discuss about important gastrointestinal ligament. The first ligament is falciform ligament. You can see it is from the liver to the anterior abdominal wall. Actually this is a remnant of ligamentum teres, that is, it is a remnant of fetal umbilical vein, and this is a derivative of ventral mesentery. Next, coming to hepatoduodenal ligament, you can see here that is between the liver and the duodenum. Okay, oh sorry, this one, hepatoduodenum, between liver and duodenum. This is a hepatoduodenal ligament. This is attaching to the free border of lesser omentum, and this is containing a portal triad. The portal triad, it contains a proper hepatic artery, portal vein, and common bile duct. So actually why this ligament is important, because here only we do the Pringle maneuver. In Pringle maneuver, try to clamp these vessels, that is proper hepatic artery, portal vein, common bile duct. Why we are clamping it? Because we want to differentiate from where the bleeding is. If the bleeding is from either portal vein or hepatic artery, if we clamp this hepatoduodenal ligament, then the bleeding will stop. But if still bleeding is continued, then you can say the bleeding is from either hepatic vein or IVC. So to differentiate that, we do Pringle maneuver, and for that we need this hepatoduodenal ligament. Again, it is also a derivative of ventral mesentery. So next ligament is hepatogastric ligament. This is one. Okay, this one, hepatogastric ligament. So this is connecting the liver to lesser curvature of stomach. It contains the gastric vessels, and even this is derivative of ventral mesentery. So all these are derivatives of ventral mesentery. Okay, like hepatogastric ligament, hepatoduodenal ligament, falciform ligament, all these are ventral mesentery. They separate the greater and lesser sac on the right, and maybe cut this ligament is cut during surgery to assist lesser sac, because if you cut this, if you go backside, that will be the lesser sac, and this is also part of lesser omentum. Next, coming to gastrocolic ligament. So this is between the gastric, that is stomach, and the colic. So according to the name of the ligament, you can easily find them. So gastrocolic ligament is having a gastroepiploic arteries. It is from the greater curvature to transverse colon. It is derivative of dorsal mesentery. So all above the stomach are ventral mesentery, back of stomach are dorsal mesentery. This is from dorsal mesentery, and this part of greater omentum. Next, coming to gastrosplenic ligament. Gastrosplenic ligament is between the stomach and spleen. So this is from the greater curvature and spleen. It contains short gastric and left gastroepiploic vessel. It is also derivative of dorsal mesentery. It separates the greater and lesser sac on the left, and it is a part of greater omentum. Okay, and it is separating the greater and lesser sac on left, which is separating the greater and lesser sac on right. That is the hepatogastric ligament. Very important. Hepatogastric ligament separating lesser and greater sac on the right, on the left by gastrosplenic ligament. Next is splenorenal ligament, that is between spleen and the kidneys. Okay, so this ligament is having splenic artery and vein, and also tail of pancreas. It is also derivative of dorsal mesentery. Now let us continue with layers of gut. So layers of gut are divided into mucosa, submucosa, and muscularis externa. So first, mucosa. Mucosa is having epithelium. You can see here, this is the epithelium. Next, it is having a lamina propria. In the lamina propria, you will find the gastric glands. Next, you have muscularis mucosa. Muscularis mucosa is a part of mucosa. Don't confuse it with muscularis externa. Okay, it is the outer layer. So mucosa have epithelium, lamina propria, muscularis mucosa. In the muscularis mucosa, you have some, you can see like villi like structures which are used for motility. Okay, actually they are not villi, but that folds of structure which is used for motility. Next, coming to submucosa. So submucosa have submucosal glands, and they also have nerve plexus called Meissner's nerve plexus. This Meissner's nerve plexus is used for Hirschsprung's disease, and this submucosa actually it controls the blood flow and secretion, and it secretes fluid. Next, coming to muscularis mucosa. You can see submucosal nerve here, Meissner's plexus. Next, muscularis mucosa. It is having inner circular layer and outer longitudinal layer. In between them you have meandric nerve plexus, also called Auerbach plexus, and this is useful for motility. It is abnormal in the case of eclasia cardia, and this muscularis mucosa is useful for controlling GI motility. Next, coming to serosa, outermost layer. The serosa layer is present only when it is intraperitoneal structure. When the structures are retroperitoneal, they have adventitia instead of serosa. Sometimes ulcers can extend up to submucosa and also into inner or outer muscular layer. So they're like very big ulcers. But erosions are always in the mucosa. Some erosions are always in mucosa. Frequency of basal electric rhythm, that is called as slow waves. Slow waves are present in GI smooth muscle, and these slow waves are originating from interstitial cells of Kajal, that is a pacemaker cells of gastric system. So the frequency of duodenum will be 12, ileum will be 8, and stomach will be 3. What are this? Actually there are slow waves. Duodenum can form 12 slow waves, ileum can form 8 slow waves, stomach can form 3 slow waves. Next, coming to Brunner's gland. Brunner's gland are only found in duodenum, that too in the submucosa of duodenum. And next, lacteals. Lacteals are lymph channels with some villi. They are useful for fat absorption. Okay, as I said already, ulcers or erosions only present in the mucosa, and they'll lead to GI tract breakage, and that will lead to dyspepsia and also bleeding and also erosion in the mucosa. Ulcers, but they can go to submucosa, muscularis mucosa, and also to little muscularis externa also sometimes if they are very big ulcers. So coming to digestive tract histology. So esophagus is covered by non-keratinized stratified squamous epithelium. Upper 1/3 is having striated muscle. Middle and lower 2/3 have smooth muscle, and they overlap at transition. Okay. So upper striated, lower smooth muscle, but it is non-keratinized stratified squamous. Okay, next stomach is having some gastric glands, you can see here, and they also have parietal cells which are eosinophilic and pink. You can see these are parietal pink color parietal cells, and they're also having chief cells which are basophilic and black. You can see this black cells are uh, sorry, they are chief cells which are basophilic, like somewhat blue in color. Pink in color are eosinophilic cells which are parietal cells. Okay, chief cells are basophilic, parietal cells are eosinophilic, and they are present in gastric glands, and those gastric glands are present in stomach. Okay, so esophagus, non-keratinized stratified squamous epithelium, upper one third striated, lower middle and lower two third are smooth muscle. Stomach have gastric glands. They are containing parietal cells. They are eosinophilic, and they contain chief cells which are basophilic. And there are simple columnar cells which gastric pits glands found in lamina propria. Next, coming to duodenum. Duodenum are having specialized villi and also have microvilli which increase absorption surface, and they also contain the Brunner's gland as we already discussed only in submucosa, and also contain crypts of Leverkuhn which contain some stem cells which replace enterocytes or goblet cells, and also they contain pennate cells which secrete defensins, lysozymes, TNF, and also they contain plica circularis which is special in distal duodenum. So plica circularis, distal duodenum. Brunner's gland in submucosa of duodenum. They contain villi and microvilli. Stomach contain gastric glands. They contain parietal cells, eosinophilic, chief cells, basophilic. There's simple columnar, gastric pins and glands are found. Now coming to jejunum. Jejunum are also having villi, and plica circularis are also present here, but this plica circularis are present in mucosa and submucosa. They are taller and more prominent, so here the jejunum villi are more prominent and they're numerous versus ileum. Ileum, they have feathery appearance with oral contrast, increased surface area. So ileum's villi are feathery, whereas jejunum villi are more taller and prominent. So ileum villi are pair patches. You can see here in the arrow D, this one, these are the pair patches which are seen in ileum. They are lymphoid aggregates in lamina propria and submucosa, and plicae circularis are present even in ileum but in proximal ileum, and crypts of lubricants are also present. Largest number of goblet cells and small intestine are seen in ileum. So largest number of goblet cells are seen in ileum. Next, coming to colon. Colon, crypts of lubricants with abundant goblet cells but no villi. There are no villi here. You can understand that colon are not having villi because in colon there is no digestion process, but the villi are present especially in the duodenum, jejunum and ileum. So these are the types of villi. Now let us check out the dual blood supply areas of colon. So the dual blood supply areas are, first one is the pancreas and the duodenum, because they are supplied by the celiac trunk and also superior mesenteric artery. Celiac trunk already supplies the duodenum and also pancreas, but the superior mesenteric arteries branch, that is pancreatico-duodenal artery, superior and inferior pancreatico-duodenal arteries also supply the duodenum and pancreas, so they are getting dual supply. And the next area is splenic flexure. This is called as splenic flexure. It is also supplied by two arteries, that is the superior mesenteric artery, as you can see here its branches are going there, and also the left inferior mesenteric artery branches, they are also supplying that is forming a marginal artery of Drummond, and that supplies the splenic flexure. Next, another area is this point in the rectosigmoidal junction, where the last sigmoid arterial branch from inferior mesenteric artery comes, and also the superior rectal artery supplies it. So there's a dual supply. So all these dual supply areas are called watershed areas, and especially they are susceptible in colonic ischemia. So next, let us discuss nutcracker syndrome. Actually, you can see in this diagram, it is a compression of left renal vein in between the superior mesenteric artery and abdominal aorta. You can see clearly this is getting squeezed here. So because of that, there will be abdominal pain and gross hematuria, and also there will be left-sided varicocele. So whenever if someone loses the weight suddenly, if someone is losing the weight suddenly, their fat pads are getting affected. So because of that, the superior mesenteric artery may compress the duodenum, and that will lead to bowel obstruction, and this occurs especially in people who are having low body weight or their malnutrition. In that case, this will lead to diminished mesenteric fat, and that will lead to obstruction of duodenum. This is called superior mesenteric artery syndrome. Superior mesenteric artery, you can see superior mesenteric artery actually forms arcades, that is a anastomosis of ileal and jejunal arteries. So vasa recta also can extend from the arcades, that is important. Okay. Next, you know that already the foregut is supplied by celiac artery and it is innervated by vagus, that is parasympathetic innervation. Vertebral level is T12 to L1 and midgut is by superior mesenteric artery, parasympathetic innervation by vagus, vertebral level is L1. Hindgut by inferior mesenteric artery, parasympathetic innervation by pelvic, vertebral level L3. Let us discuss the branches of celiac trunk. So actually celiac trunk are having branches like common hepatic artery and splenic and left gastric. So actually this is the splenic, this is the left gastric. Common hepatic artery here you can find, right? This is a common hepatic artery, this is a splenic artery, and this is the gastric artery, left gastric artery, this one. And these constitute the main blood supply of the foregut. So foregut is nothing but esophagus, stomach, okay, esophagus, stomach, liver, gallbladder, spleen, and the part of duodenum and also pancreas. All these are supplied by this. There's a strong anastomosis especially between the right and left gastroepiplaque, and also this is gastroepiplaque here. This is the left gastroepiplaque, right gastroepiplaque. Here there's anastomosis, and there's also anastomosis between right and left gastric arteries. You can see this is the left gastric, this is the right gastric. Once let us see all these arteries. You can see this is the abdominal aorta, this is the esophageal branches, this is the left gastric, this is the right gastric, and next this is the gastroduodenal artery, this is the posterior superior pancreaticoduodenal, anterior superior pancreaticoduodenal, and this is the right gastroepiplaque, left gastroepiplaque. Here comes the short gastric arteries. So you can see this a whole purple color, that is splenic artery is giving rise to short gastric arteries and left gastroepiplaque arteries. You can see here this is all the right gastric artery. Right gastric artery is coming from a branch of proper hepatic. You can see proper hepatic is giving rise to cystic artery. It is also giving rise to right hepatic and also left hepatic, and this is mainly the common hepatic artery. So common hepatic artery is divided into proper hepatic artery, and it is dividing into the gastroduodenal artery and also the right gastric artery. Okay, left gastric artery is coming directly from the celiac trunk. So these are the different branches, and gastric ulcer is most common in the lesser curvature of the stomach. So it may rupture the left gastric artery and that will lead to bleeding. Posterior duodenal ulcers mainly rupture the gastroduodenal artery, this one, okay, and that will lead to bleeding there.